Presentation will be on the physical demands of running, specifically the kinematics and the kinetics. We won't really talk about the energy system demands that will be preserved for additional presentations. As an orthopedic and sports physical therapist, I see a lot of individuals that are trying to return to running after injury. As such, I've come across the question of what are the physical demands of running? If we're going to get someone back to it, then we need to ensure that our interventions and our process are sufficient to be able to get the patients and the athletes and the clients back to a sufficient amount of physical capacity such that they can endure the physical demands of running. That being said, these physical demands have otherwise been to some extent elusive. And so I want to put together a series that will better clarify what are the physical demands and what are the standards and thresholds that we need to get someone back to in order to endure such a wonderful event and task such as running. Okay, so I think it's important to first ask the question, like, what are the incidence and the prevalence of running-related injuries? So a systematic review in 2021 looked at the incidence and prevalence of all the different musculoskeletal injuries that can be accrued due to the task of running. And they've broken it up and dichotomized it into ultramarathoners and non-ultramarathoners. The I's indicate incidence, the P's indicate the prevalence, and then the specific locations along the body are where the highest incidence or lowest incidence and the highest prevalence and lowest prevalence are shown. So overall, the prevalence, that is at any one given time, almost 40% of runners, that is conglomerate and aggregate of both of these groups, would accrue up to 40% of individuals are either nursing or dealing with a running related injury. Within a given annual year, about 45% of runners can accrue some form of musculoskeletal injury, with the highest point prevalence being around the patellofemoral joint, that is the knee, closely followed by the Achilles tendinopathy, and then the foot and the ankle, which we could classify into medial tibial stress syndrome or shin splints, also known. And so taking this into account, it's clear that there's an issue. As a healthcare provider and sports medicine professional, my goal is to try and mitigate both of these statistics, the prevalence as well as the incidence, and help people back to pain-free and unencumbered running. So a common saying that is out there is that we need to be fit to run rather than run to get fit. But the elusive question is, how fit do we need to be, and what are the physical demands of running on the musculoskeletal system such that we can mitigate both the prevalence and the incidence of running-related injuries? So let's dive into it. So let's take each of the body regions in turn, particularly for the lower quarter, because that is, as we saw on the diagram previously, are where the majority of the injuries are accrued. And so I want to start with some of the seminal studies. There's two of them specifically that have helped us to identify the physical demands of running. The first of these seminal articles is Dorn et al. In 2012. Again, slightly dated, but it is such a seminal study that it stands the test of time. So their purpose was to describe and explain synergistic actions of the individual leg muscles over a wide range of running speeds, from slow to maximal sprinting. Though it is a small cohort of only 9 individuals, both males and females, almost 50-50 split between the genders, because it was done on such a granular level, that is the outcomes and the metrics that they took were so specific that it really does help to give us some insight, again, with the necessity for additional extrapolations, but studies since this have found comparable metrics and outcomes, despite the small cohort here. So the running speeds, again, they went from 3.5 all the way up to greater than 8.0 meters per second. For those that are more familiar with the English units, that's 7.8 all the way up to 20 miles per hour, which is a full-on sprint. So they use timing gates, a 3D motion capture system via Vicon. They looked at the ground reaction forces, which is the amount of force that someone puts into the ground, and they did so with in-ground force plates. So I've taken the liberties of taking the results and graphing it because I think it's more powerful in the visual. So if you had to project the muscle groups that are most in demand or most stressed with running, most people would either suggest the major muscle groups of the thigh, that is the quad or the hamstring, and even maybe perhaps the hip muscles of the glute. But the reality is that the workhorse is the soleus and the gastroc, that is your calf muscles. And you can see that indicated here. On the y-axis, you have your peak force in body weights, and then you have the different running speeds that they've looked at. So for those who may not be familiar, these are like times of body weight. So if you looked at 7.8 miles per hour, and I've provided the statistical values there, so you can see that the quadriceps produces 4.7 body weights for every step that the individual takes. That being said, the soleus is at 6.7 times body weight. Not only is that more, but when you look at the the size and the cross-sectional area of these muscles, you don't need a medical degree to understand that the people's thighs and quadriceps are significantly thicker than that of the soleus and or the calf muscles. Thus, they are working at a higher capacity, not only relative to the muscle size, but also a net significant difference and higher. And you can see that there's a gradual increase in the soleus demand up to 14 or almost 15 miles per hour. It then does drop off because the amount of time that the foot is on the ground is shorter as you get faster and faster into sprinting, and thus the muscle doesn't have the opportunity to really be able to contract with as much force because of the small time interval. And what we will see in the coming slides is that the hip muscles actually take over as someone crests from what is a very fast jog, we'll call it, up to a sprint. But the take-home message is that the major muscle groups and players are certainly the quadriceps, but not to be overshined by the calf muscles, that is the gastroc and the soleus, with the soleus being significantly higher work demands than either of the other two muscles. And then this is what I was describing with the time intervals that the foot is on the ground. So they're producing these forces in fractions of a second. So what I've done here is I've just divided those body weights per second. So instead of just looking at the strength, we're looking at power. Power is being defined as force over time. So when we take that into account, we can see that they're producing multiple body weights per second, exponentially more than what we saw in the previous slide. And when we take that into account, again, you see kind of a leveling off of the soleus and the gastroc as you get into those faster running speeds. And when you're looking at peak force for the swing phase, that is the non-stance limb, what we can see is that there's an exponential increase in two major muscle groups, and that's going to be your iliopsoas. People also know this as a hip flexor, and then also your hamstrings. Once again, we can see exponential increase in the number of body weights. So depending on how heavy someone weighs, that would be an indication of that they're, even at a low jogging speed, that these muscles are working at close to 2 times, if not 3 times body weight. And that exponentially gets up to almost 9 times body weight during the swing phase of sprinting. And you can see that there's a jump in their activation as you get into that faster sprint, which again takes over and helps to produce the power when the gastroc and the soleus and the stance muscles are having a smaller interval of time to be able to produce their force. So the figures here look at the stride length as well as the stance time over the different running speeds. So on the y-axis, you have either how far they're striding and or the stance time. And then on the x-axis, you have the different running speeds over time. So if we take the first graph, we can see that stride length significantly increases as we get up to, again, around 7 meters per second, and then it somewhat tapers off just because you can't, there's going to be limited, essentially a ceiling effect there, but the actual stride frequency continues to increase and takes over for the stride length once that is maximized. And then in the time graph that we see on the bottom, where we're looking at the ground contact time, the black line, we can see, as I alluded to, there's almost like a linear decrease in how long the foot is on the ground. But there's also an aerial time that continues to increase up to that 7 meters per second. Where the effective vertical ground impulse, how much force they're putting down into the ground, again, continues to be able to kind of increase up to your 7 meters per second and then somewhat tapers off. And so because of the bottleneck, which is how short of a time interval that the foot is on the ground, we then can see the compensation by the 25% increase as people start to spin their wheels faster with higher frequency of steps. So for speeds less than 7 meters per second, the plantar flexors and soleus contribute most significantly to the vertical support force, hence an increase in stride length. And then speeds greater than 7 meters per second, these muscles shorten at relatively high velocities, and that has less time to generate the forces needed to support the body. And thus, greater than 7 meters per second, the strategy used to increase running speeds shifts from the goal of stride frequency once that stride length has been maximized. The hip muscles, primarily the iliopsoas, glute max, and hamstrings, achieve the goal of going faster once we accelerate beyond that 7 meters per second. So the second seminal article is by Hamner and Scott Delp, and they looked at the muscle contributions of fore and aft and vertical body mass center accelerations over a range of running speeds in 2013. Again, slightly dated, but given how rigorous and how influential their work with, it still has stand the test of time. And it's, again, the purpose was to examine how muscles generate acceleration of the body center of mass. Again, they had a comparable cohort relative to the Dorn article. Their conditions, they used 3D muscle-driven simulation of running. They had different speeds, 4 of them comparable, again, to the Dorn article, with the exception that their speeds were slightly lower. They didn't go all the way up to sprinting. They did 7 mid to rear foot strikers, the 3 forefoot strikers at all running speeds. And then they used comparable Vicon 3D motion capture systems and OpenSim. Their difference here, obviously, that they had EMG activation electrodes on 10 different muscles. So talking about the ground reaction forces. So this would be the aggregate ground reaction force of a single step during someone's stride. On the x-axis is time, on the y-axis is the acceleration, and the length of the lines that you see indicate the intensity or the magnitude of the ground reaction force. That is the amount of force that is put into the ground and that is hitting back at the body. And then the direction of the lines indicate whether that's braking force. So if it's pointing to the left, those are braking vectors, meaning that they're working in front of the center of mass. And then the angled lines that are pointing to the right indicate that they are accelerating the body forward and acting behind the center of mass. And you can see that on the whole, as an aggregate, that there are a slightly leaning bias of the greatest magnitude or vectors that are pointing slightly into a braking force, but for the most part, they translate the center of mass forward over time aggregately. And so if we break this down further, let's look at what muscles contribute to the acceleration or hitting behind the center of mass, pushing it into an acceleration into the next step. And we can see that at almost all time points, the gastroc and the soleus, as shown there, respectively, soleus on the left, gastroc on the right, indicates that these are, again, the workhorse. They are pushing the center of mass forward. The quadriceps, on the other hand, are working as in a braking fashion. They are absorbing force, and the fact that they're all vectors are pointing to the left indicate that they are braking. They are hitting in front. They are working against the forward progression of the center of mass of running, as if someone is running from the left to the right hand portion of the screen. You can also appreciate, once again, the amplitude. Again, I've tried to position it to scale to some extent, at least between the gastroc and the quadriceps. But then look at the exponential scale. It's almost 10x for the soleus. And then the glutes, again, this is disproportionate, not to scale because of the 1 to 0. And what we see here is that the glutes have pretty much more of a vertical element to them compared to the bias of the acceleration of the calf and the braking forces of the quadriceps. And this is, this starts to get at the demands of running and how important it is for these muscles to be strong in the muscle function that they work in during the running, meaning that we need really strong eccentric control with our quadriceps. That means they need to be really good at absorbing force, whereas the concentric, the force production during the muscle shortening of our calves is really important for the speed and the power of running. And I highlight again, the 10x scaled soleus there. So in the early stance phase, the quadriceps group are the largest contributor to the backward and upward mass center acceleration in each step. In late stance, the ankle plantar flexors, soleus and gastroc were the main contributors to forward and upward center of mass acceleration. Again, the soleus is a dominant contributor to the increase to the vertical and to the forward center of mass acceleration at all running speeds. Large mass center essentially accelerates from the soleus, occurs because of the muscles produces a large force and is uniarticular at the ankle, versus the gastroc is dual. It works both at the knee and at the ankle, and because it works secondarily as a knee flexor, its capacity to accelerate the center of mass forward is somewhat dampened. And here's a proportionate visual of what I kind of showed on the last screen. We have vertical acceleration on the y-axis, and we have the different muscle groups shown on the x. Once again, it's like almost 10x what we see from the soleus contribution compared to any other muscle at any one running speed. And then we have the horizontal ground reaction force. So if we take a moment just to understand the diagram. So 0 is essentially no movement. And then anything that's to the left and pointing backwards, similar to the vector lines that we saw in 2 slides back, indicates that these muscles are working in a braking fashion. They're working against our forward progression, as if the individual, as shown there by the small diagram, is running from the left to the right hand portion of the screen. And then anything to the right of the 0 are indicating that it's moving the center of mass forward. So it's really showing the horizontal vectors. So the forward acceleration force of plantar flexors was greater than the total forward center of mass acceleration, where the quad continues to accelerate the center of mass backwards against the propulsion. So not only does the soleus have to move us forward, but it's got to overcome the vector of the vastus lateralis and the quadriceps. And you can see the gastroc and the soleus demonstrated there as they are propelling the center of mass forward. And then I provided the specific numerical values as well. And then this is the velocity at which someone is running. You can see the different shades indicating the different running speeds. And again, at any one given time point, the soleus and the gastroc contributions have to be greater than that of the velocity forward, from the standpoint that they have to overcome the negative work and the braking forces of the other muscle groups. And this has really big implications in why quadricep strength and the larger major contributors at the hip and at the thigh are so important when we do strength testing in preparation for someone's return to running. And we'll continue to explore the demands of running for each individual joint moving forward. But I think that these two studies combined really give us a high-level overview and a really in-depth analysis as to what the muscle contributions are and what their demands need to be in order to be successful at this task. So this is a modified slide from Dr. Rich Willey. He's a profound giant in the field of running and specializes in bone stress injuries. He has a wonderful Instagram. If you don't follow him, I strongly encourage it. But he does some excellent visuals with his slide deck, and I've modified this from one of the slides that he has previously presented. So kudos to him. And then I've cited the source that he cited as well for the information. So one of the reasons why knees get are such challenged with running, we saw the incidence and the prevalence earlier in the video, and that is the highest point of musculoskeletal complaints in running related injuries, is the exponential increase in force that comes between walking and running at the joint. So when we are walking, we need 5.5 body weights with every step at our hip. For our patellofemoral contact forces, it's like 1.1, and then our Achilles tendon forces are like 3.4 times body weight. And then running, at least at 7.5 miles per hour, this would obviously, as we saw, increase as we increase in speed, but we get about a 1.8x increase at the hip, but we get a 4.6 times increase at the knee. Where our patellofemoral contact forces jump from 1 to 5. And then the peak Achilles tendon force, again, this being the conduit by which the gastroc soleus is able to produce its forward acceleration, increases by comparable to that of the hip. So the joint that is most responsible, it takes the greatest impact, and I really do believe it's because of the braking forces and the shock absorption, the energy absorption that the quadriceps and the knee have to do with running, takes a much larger exponential impact when we transition from walking to running. Okay, so that wraps up this part one of this series on looking at the demands of running. Thanks so much for listening. If you have any comments, questions, or concerns, I certainly will happy to field those. Leave them in the comments section below. Thanks so much. All right, this is part two in a series of videos on exploring the physical demands of running, a needs analysis, and understanding what the human body needs the prerequisites are before we get someone back to running at full capacity. And in this video, I'm just going to use what evidence that currently exists. There's a plethora of it around the knee, and I'm going to use a case example to kind of set the stage, because it's going to frame how we consider the necessary prerequisites for running for each of the other joints, that is the ankle as well as the hip. Okay, so when we're looking at the industry standards for returning to running, we'll use the knee as our exemplar, simply because there's the most information that has come out regarding that, particularly around ACLR. That being said, oftentimes that criteria is extrapolated and utilized for other pathologies as well, not only at the knee but also at the hip and the ankle, which we'll talk about that criteria. But if we're thinking about a clinical case that I'll present here in a moment, let's just ask ourselves first, like, what would the industry guide? How would it guide us as far as best practices? So here's a survey that was done internationally for physical therapists, and for your clinical assessment across the Netherlands, Australia, as well as France. You can see the criteria listed in the columns there, and then the essentially clustered horizontal bar graph showing where the consensus was highest. Specifically, they would expect or they would recommend that time since injury, the overall ACLR RSI, which is someone's psychological readiness for return to sport, swelling and pain, and then clearance by surgeon really make up your top 5. So when we look at that same study in regards to the physical and performance-based tests that are recommended by physical therapists across this international survey, we see that single leg squatting would be second, knee extension strength being number 1, and then drop vertical jump being number 3. Close in that fourth category, fourth or fifth criteria would be our knee flexion, that is hamstring strength, and then also hop testing. The overemphasis on the knee extension strength versus the hamstring strength really, I think, is explained by the muscle's role during running, where the quadricep is going to be the muscle that predominantly works eccentrically to kind of buffer and shock and load attenuate, thus protecting the joint more so than the hamstrings, even though it would be good for there to be adequate muscular balance around the knee joint. So if we take the industry standards as far as the specific tests and assessments that are recommended, what are the said criteria for said tests? Okay, so a seminal study was Rambod in 2018 when they did a systematic review as far as the criteria that would be recommended for returning to running post ACLR, and their recommendations were that it should be time-based with a median of 12 weeks. An early onset initiation of running would be 8 weeks, with a more protective focus being at 16 weeks. Clinical examination, knee range of motion, pain, knee extension, and effusion, they should all be full range of motion or greater than 95% of the uninjured limb. Pain should be less than 2 on a visual analog scale, full knee extension, and no effusion. When we're looking at strength, so you want at least 70% from the other limb, and for the quadriceps and hamstrings respectively, you would want close to over 70%. One study did denote an 80% strength limb symmetry index. For performance-based testing, similar to what we saw on the last slide in the last survey, this just gives us specific criteria. So hop testing LSI, if you're going to incorporate that, should be 70 to 80% limb symmetry. Wide balance can be considered. There should be a proprioception LSI of 100%. And functional tests such as your 10 single leg squats to 45 degrees without loss of balance would be 70%, whatever your metric is. Maybe it's your knee varus or valgus, or number of repetitions. There's also 30 step and holds without loss of balance that also is more of a qualitative assessment and coordination movement pattern. Normal gait pattern would be recommended. What is normal? I think that also is somewhat ambiguous, given the fact that a lot of clinics don't have the 3D motion capture or even 2D motion capture to really quantify this. It's going to be more subjective to the eye of the beholder of the therapist, and where we know that the human eye captures 30 frames per second. Really, in order to be able to adequately and accurately assess someone's at least running gait, it would be recommended that you have 240 frames per second. So a video analysis would be necessary. It's not really specified here whether they're talking about a normal gait being just walking or with running. A recommended approach, using a time-based criterion plus strength and performance-based assessments that are individualized with the decision-making would be recommended. So keeping this criteria in mind, let's take it to our clinical case. So our clinical case is a male who's 39 years of age. He has no pain or knee effusion. He's greater than 6 months out of a meniscectomy. Full knee extension with knee flexion greater than 90% LSI, quadriceps and hamstring strength greater than 80% LSI. Here's his testing results of an isometric test for quadriceps on an isokinetic dynamometer done at 90 degrees of flexion. You can see that he's producing really good forces relative to body weight with a peak torque to body weight percentage on the healthy limb at 91%, and then the involved limb on the right, he's at 71.9%, and that would put him at an 80% limb symmetry indices for his quadriceps. His hamstrings were even more superior than that in regards to their limb symmetry. 3 months progressive strength training is what he has undergone. He's performed single leg step down greater than 10 repetitions with good form and able to perform low level plyos, which include jumping on the spot, double limb, single limb, side to side, double limb, single limb for multiple repetitions, and then also forward and backwards. Now, and he's performed this for twice a week for 2 weeks, so 4 sessions total without any repercussions. So I think based off the industry standard, it would be recommended that this individual would meet the criteria necessary for running. So if we go ahead and look at his gait, and I'm really going to try and make an argument for the importance of considering our movement analysis as well as the incorporation of rate of force development, essentially someone's muscular power rather than just their strength. I have 2 videos here of a individual running on a treadmill. Note the date of when it was taken, January 10th, 2024. So there's a right-sided view, and then we'll also look at the left-sided view. And yeah, what I would encourage you to try and discern is if there's any deviations from one side versus the next. Start up the other side as we look at that. So from the left, again, looking at joint angles at the 3 major muscle groups. Consider the vertical oscillation as well. So if you look at the video on the right, we'll use that as an exemplar. Look at the waistline as to how much it oscillates from one limb to the next. So as he lands on his left, his shirt sinks below the edge of the treadmill versus on the right it stays above. That also corresponds with the knee flexion angle that we see and the amount of what they call joint excursion. So the amount of knee flexion that he gets from the initial contact to mid stance. On the right side, he's quite stiff. The knee doesn't really go through any excursion from the initial contact to mid stance versus on the left, you can see he hits almost with a straight knee and then he lands very compliant on that. All right, so we'll move forward, but keep this in mind, not only the date and the deviations that we see. So a big shout out to Dr. Rich Willey, who is a giant in the field of running. He runs the University of Montana running lab. This is an image directly from a September 27, 2022 post on his Instagram, Mountain Running Lab. And I encourage you to follow him. He puts out some extremely good content that is educational, informative, science-backed, and I think also really visually easy to comprehend some of the difficult, complex concepts that he conveys. So I'm going to use this as an exemplar to demonstrate that individuals post ACLR, and we're going to use the ACL reconstruction patient as an exemplar for those individuals that also have other knee-related conditions and pain because they demonstrate comparable deviations with their running. And in this case, individuals post ACLR underload their knee, and we see this with the stiffened gait as we saw in the previous video. The things that you can see from the left versus the right, the left being the injured individual rehabbing or coming back from their ACL reconstruction, the right being the healthy control. You can see that the knee flexion angle is less on the left side. Again, they're underloading the knee joint as well as the quadriceps. That leads to the two things, one or maybe even three. So one, it leads to an underloading of the quadriceps and thus continuing to perpetuate the quadricep weakness over time. Quadricep strength is a wonderful vital sign for how healthy your knee is and will become. Secondarily to that, it underloads the cartilage, which is necessary in order to maintain healthy homeostasis. Specifically here, we're talking about the patellofemoral joint. That is where your kneecap interacts with the femur. You can see also that the knee joint center is much closer to that red line, which indicates that the amount of torque that's going through that knee joint is less compared to what we see on the right. Additionally, you can see that the ankle center joint is much further away from the red line compared to the one on the right, indicating that the load shifts not only up but also down the chain to both the hip and the ankle. And so with running, we get worsening patellofemoral joint osteoarthritis over time, which is a problem. A lot of these individuals that are accruing these knee-related injuries, particularly ACLR, are younger, and so it's really devastating that within a 10-point time point, they have a 6-fold increase in their osteoarthritis. Depending on the study and the research that you follow, but regardless, we know that they're at an increased risk. Subsequent information that's, I think, for me, really impactful and keeps me up at night is even with individuals that are going through a stiffened knee gait with walking, they have associations of synovial fluid and osteoarthritis biomarkers. So there's been a strong correlation to show that individuals that come off their crutches and or their brace and in their attempts, with best of intentions and goodwill, they're trying to just walk normally and get back to their lives. And again, they're as therapists and sports medicine professionals, we need to be part of the solution rather than part of the problem. It's not okay that they're walking around with stiffened knee gait. This is associated with, you can see the SF, which stands for synovial fluid for the interleukin 6, which is an inflammatory marker. So they're taking the fluid directly out of the knee joint, and this would be an increase in the interleukin 6 is something that you see in individuals that have osteoarthritis. Secondarily to that, you also have the serum C2C, so this is taken out of the blood, as well as the serum MMP3, which is the matrix metalproteinase 3. These are biomarkers associated with cartilage degeneration and remodeling, particularly in the context of osteoarthritis, and are important for joint-related health. And so if they become elevated, this is, again, the early signs of the changes that are going to promote a cascade of events that leads to the early osteoarthritis. And again, this is with individuals with walking. So individuals demonstrate altered gait patterns even with walking at faster speeds, even at slower speeds, but can be augmented with faster walking. And as we saw in part 1 of our video series, is that at the knee joint, when you go from walking to running, that there's a 5x increase in the patellofemoral joint stresses. So if we're already getting early onset biomarkers with our walking gait, and their individuals are walking around with an antalgic and stiffened knee, it's a problem, not just because of the secondary compensations that occur within the musculoskeletal system, because it is one of the early movement vital signs that is going to be an indication and lead to the degeneration of the knee joint over time, which then compromises quality of life, autonomy, agency, and then eventually can subsequently lead to secondary non-communicable health-related diseases. Yeah, so it's a problem. It's something that needs to be addressed, and yeah, we're seeing it in the running, as I showed in the previous video. But yeah, we need to even take a step back and consider it for the gait as well with walking. Okay, so quick orientation on the y-axis. You have the negative work in joules per kilogram, and then running across the x-axis is time post ACLR in months. So you have the pre-injury state, the 4 months, 6 months, 8 months, and 12 months. And then there's going to be 2 bars that populate. So the first bar that does not have the black lines, the black diagonal lines across it, is the injured limb. And then the bar or within the clustered histogram that has the diagonal black lines is the injured limb. You can see in the white is the negative work or the shock absorption that is done for the hip. The light gray is going to be the knee, and then the darker gray is going to be the ankle. So if we look at how the different joints are affected by the ACLR and across time, we can see quite dramatically that the knee is most significantly affected with a stiffened knee gait pattern where there is a little joint excursion, which is expressed as the reduction in the negative work that is done during the running, during the stance phase of the running gait. We previously established that even with individuals that are walking with a stiffened knee gait post ACLR, that this can be caustic to the knee joint, showing biomarkers both within the synovium of the joint as well as in the blood, that this will potentially lead to early onset of osteoarthritis. Now that the forces are even further exponentially increased due to the higher rate of loading and the associated flight phase of running as compared to walking, that this would only further be detrimental to the knee joint and promote a lot of the osteoarthritis biomarkers that are seen with walking. And as we track this across time, we can see that it's persistent. So in this cohort, even at a year out, that time in itself just does not normalize the negative work that is performed. In fact, there's a shift. As you can see, there's a gradual increase in the shift as far as the ankle shock absorption, a fluctuation in the hip depending as far as like the amount relative to the pre-injury state that fluctuates from what regarding the time point, right? So be it 6 or 4 or 8, the hip seems to fluctuate a little bit, but definitely a stiffened pattern within the knee joint that's not restored at a year out. So running knee flexion angle post ACLR, on the previous slide we looked at the negative work that was done, which correlates quite strongly with that of the knee flexion angle. This is something that's a little bit more easily observable and more clinically friendly and relevant. So in the running image, on the injured limb, you're looking at a knee flexion angle of 34 degrees versus the healthy limb their knee flexing to 48 degrees. So you want a greater sagittal plane knee flexion angle during the stance phase. Here we see the stance phase knee extensor impulse is 27% less, which is also associated with that 14-degree difference in the max knee flexion. Once again, you can see this graphed across time. So on the y-axis here, instead of the negative work, you have the surrogate measure of peak knee flexion. You have the surgical limb in black, the non-surgical limb in the light gray, and then you're looking at peak knee flexion during running post ACLR across time. Once again, you have the 4, 6, 8, and 12 months, and comparable to that of the negative, the loss of negative impulse that was seen on the and negative work that was seen on the previous slide, that correlates very strongly with the knee flexion angle. So it's not okay that people are coming off these injuries and walking with a stiffened knee, and it's certainly not okay that they're doing so with their running gait as well. And it's not, we can't run under the assumption that just allowing this to occur across, just letting time transpire is going to fix it, because it's clearly that's the data would suggest that it doesn't. And this in itself is enough to cause the increased risk factor of knee osteoarthritis moving forward. And that's what we see at the 10-year mark, where people are at a significant increased risk as compared to their healthy cohort, as well as to their opposite limb. So the take-home message here is that strength is good, but power is better. So individuals with greater than 90% quad rate of torque development limb symmetry index had an average of 27.4% greater knee kinematic symmetry than those that had a lower than 90% limb symmetry index on their rate of force development. For every 10% decrease in rate of torque development, LSI, there is a 0.9 degree decrease in the knee flexion difference during running. And for every 10% increase in the rate of torque development limb symmetry index, there is a 3.5% increase in knee flexion symmetry during running, i.e. this is an enhancement in the symmetry in the knee extensor moment. And so on the y-axis here, we have the knee extensor impulse, the limb symmetry index, and then we have the quadriceps performance running across the x-axis. The rate of torque development is shown in the lighter gray, and you can see that it has a stronger correlation with the knee extensor impulse than does the quadriceps strength, and is a better predictor of what their impulse actually is, because of the more linear correlation that you see. So if you drew that dotted red line at 80% knee extensor impulse LSI, suggesting that would be an acceptable amount of symmetry that would potentially be less detrimental to the joint, then we could say that would correspond with an individual getting their rate of torque development symmetry also to about 80%. That being said, when someone's quad strength is at 80% or even at 90%, they're still well below that threshold bar of knee extensor impulse. Thus, they're still likely running with a knee straight or stiffened position, and they are not properly shock absorbing through their knee like they would naturally do in their pre-injury state or on their other limb. This is a slide from Dan Cobian from CSM 2023. It's a little bit faint. I apologize. It is a photograph. And so on the let's look at the first graph on the left. So we have running knee extensor impulse. limb symmetry index going from 0 to 120%, and then running across the x-axis is the quadriceps rate of torque development, LSI. And it's important to note how the rate of torque development is quantified here. So there's different metrics, and the first you can take rate of torque development at as a slope or instantaneous. You can take it at 100 milliseconds. You can take it 200 milliseconds. The way that they do it at the University of Wisconsin is they look at rate of torque development 2080. Specifically, they look at the amount of force that is produced between the time interval that is taken between their peak force curve at 20% of their max and 80% of their max, and divide it by the time interval. And that's how you're getting the quantification of the rate of torque development, and then you're looking at that from side to side. So if we're interpreting this graph, so you can see the yellow shaded bars, just with the red bar kind of indicates the lowest threshold of acceptability of the knee extensor impulse, such that the individual is starting to load their knee well. Then where does that kind of correlate with the acceptability of rate of torque development? So at least 70% LSI of their rate of torque development would be recommended in order to ensure that the individual is adequately loading their knee appropriately and not landing with a stiffened gait. That being said, 100% is better. And if we draw that line, because if we measured the rate of torque development, and we held the individual to 100% side to side limb symmetry, then we could say that nearly all of the individuals at that rate would be able to have a more symmetrical impulse over 90% from side to side. That being said, when we look at this, not so much from a limb symmetry index, but when we look at the rate of torque development relative to the body weight. So in the second figure, you have running knee extensor impulse, same as you did on the first graph. The x-axis here is the involved limb rate of torque development, and it's quantified by Newton meters per kilogram per second. So they've normalized it now to the body weight of the individual. This is at least, you would want at least 9 millimeters per kilogram per second. But if you have 12, that would be better, because a much larger percentage of the individuals would be above that 85 to 90% LSI for their running knee extensor impulse. If you wanted to quantify this from the metric units to the imperial units, you would simply divide by 3. So if you're going to measure someone's rate of torque development 2080, then you divide it by their pounds of body weight, it would be at least 3 foot-pounds per pound per second, and a better cut point would be 4 foot-pounds per pound per second, in order to ensure that their knee extensor impulse was sufficient. So if we revisit now our case study, as I alluded to, that his LSI was greater than 80%, or at 80% isometrically, strength relative to body weight was 70%, and I had expressed the other criteria that he had also met on a clinical standpoint. That being said, when you look at his rate of force development, this in itself explains the deficits that we see in the inadequate knee flexion and joint excursion that is shown with the videos. So the involved limb on the top row, healthy limb on the bottom, you can see the rate of force development at 2080 relative to body weight, so foot-pounds per second per body weight. On the involved limb, it's 2.2. It's shy of that 3.0 that we spoke about in the previous slide. And his healthy limb is close to that 4.0, which would be optimal. Moreover, beyond just that, you can see the LSIs for his rate of torque development 2080 being at 56%. his rate of force development at 200 milliseconds being at 68%, and then his peak torque limb symmetry index being at 80%. So it would suggest that this is a prime example that power is more, strength is good, but power is better, is the short story. And the power metric that you look at also matters. You can see that the rate of torque development, rate of force development at 200 milliseconds is limb symmetry is much, a meaningful margin higher than that of their rate of force development at 2080 at 56%. So my argument and my point being is, yes, we can have all these criteria that the industry would recommend, but yet even despite having this criteria available to us, our patients are still experiencing an increased risk of osteoarthritis at a 10-year time point following their ACLR and other knee surgeries. And I think that looking beyond just what criteria currently exist, I think that muscle power is important. I also think that it's critically invaluable to be able to do an adequate running video analysis, to be able to really ensure that the individual is adequately flexing and going through joint excursion and shock absorbing to protect their joint. I would also make the argument that as of right now, it's kind of been trial and error, the establishment and or expert opinion, the establishment of these criteria for return to running. And really, I think the better strategy would be to look at the specific physiological demands at each joint for running, and then base our criteria off that rather than on a trial and error approach. We are much more advanced in that in our scientific methodology, and so our clinical practice should also reflect that. So sticking with the knee, let's look at the physiological running demands of the kinematics of the knee during running. So the column headers, you have the different speeds of running because the kinematics of the joint are going to be dependent upon that. I've listed them off in miles per hour based off the study that is cited at the bottom, Ordendorff, 2018. And then in the row headers, you have knee extension, knee flexion, and then the overall joint excursion. So you would see that at initial contact, the individual's slightly flexed at anywhere between 12 and 13 degrees with a faster running speed associated with more knee flexion at initial contact. Knee flexion angle is going to be around 42. Again, as speed increases, the range of motion demands are going to also increase, and then the joint excursion is also going to increase as well. And so to give a visual representation of what we're talking about with the initial joint excursion, it's taking the initial contact and then looking at the stance reversal at the point of greatest knee flexion. Now, the joint excursion here is less than what you see in the table. Specifically, you can see going from 149 to 139, that would be a 10-degree joint excursion from initial contact to the mid stance or greatest point of knee flexion. That being said, you can also appreciate the fact that this individual is striking not on his heel, but more on his midfoot. Thus, there's going to be a greater attenuation of force through the ankle joint, where he's going through currently almost 17 degrees of joint excursion because he's in slight plantar flexion, and he's going to 80 degrees of dorsiflexion, which would be 10 degrees of dorsiflexion. But these were the point of the picture in the images are really to give you a visual representation of what the knee angles in the table represent and the points during the gait at which they represent. So it's good to keep in mind that what we would expect to see from our knee range of motion, our kinematics. The other two variables, right, are going to be the kinetics, specifically the force. Like what is the actual force that is needed in regards to body weight with running at the knee, and then also what is the power that is represented or necessary. So the running demands for the kinetics of at the knee joint, specifically the quadriceps and the hamstrings, respectively, are shown here. So when you equate the Newton meters per kilogram in regards to, so that's normalized to body weight for knee flexion and extension moments, you can see that from knee extension, depending on the running speed, that you would need anywhere between 73.5% of body weight up to 90% of body weight the faster that you run. And then knee flexion would be just a fraction of that, again, just speaking to the different roles that the muscles play during the act of running or the task of running. And so this gives us good guidance that really we should be expecting the quadriceps to be able to produce anywhere between 73 to about 90% of body weight, and that should guide our thresholds and our criteria, rather than just whether someone can be successful at performing said running gait. This I think would be a more specific and better rationale than just taking industry standards at face value. Yeah, as we've made the point, hopefully, that what matters more than strength is power. And so muscular power should be considered if we are going to try and ensure that someone's knee extension impulse and their sagittal plane knee flexion angle is going to be in an acceptable range of 85 to 90% limb symmetry. So the knee joint power, you can see the concentric knee extension torque or rate of force development, foot-pounds per second per pound body weight is shown for the different running speeds. And then you can also see the knee extension for the eccentric. Obviously, the eccentric being more important than that of the concentric, because that's the muscle function that is protecting the joint during the loading during running. You can see that these numbers correspond pretty readily to what we had spoken about, with anywhere between 3 to 4 foot-pounds per second per body weight being what is recommended. So the eccentric values are directly in line with the University of Wisconsin's recommended RTD 2080 normalized values. And to ensure that 80% LSI in running knee extensor impulse post ACLR, but using that diagnosis as well as the knee criteria as exemplars that can be extrapolated to other diagnoses and other joints, which we will do here in a moment. So the testing criteria, so often I find that knee extension rate of force development is something that's not commonly tested, and the industry criteria would otherwise suggest or reinforce that. Oftentimes you want to do this, I think it's necessary and mandatory to do it isometrically in a seated position, 90 degrees of knee flexion, 90 degrees at the hip, and then the sets and reps should be 3 sets of 5 seconds. The running ideal cutoff would be 3.0 foot-pounds per second per pound of body weight, as discussed, and then the outcomes torque per second. Again, you could take the rate of torque development at the different time points. I think that the rate of torque development metric that corresponds more readily to someone's knee flexion angle is going to be the RTD 2080 normalized to body weight. And then if you are going to utilize the 100 and 150 milliseconds, it's important to prospectively establish like what your time point zero is, and your rate of torque development time point zero is when the resting torque exceeds the toe peak. That's you were talking about the time force curve. Once that time force curve exceeds 2.5% of the resting torque or resting load, that would be your time point. That data point would be your time point zero. Without going too far into detail, but the sampling rate of whatever machine that you're utilizing should be high. It should be at least 100 hertz. That is 100 samples per second. And there are devices on the market these days that are not isokinetic machines that can do sampling rates up to 1,000 hertz. So it is becoming more readily available and affordable, and I think it should be tested. To follow up on that point as to what equipment I think would be recommended in regards to testing someone's muscle performance, regardless of what muscle group we're discussing, I've highlighted the 5 muscle groups that I think are going to be most important for running, which are the major muscle groups of the lower extremity, which include the glute, that is the glute max, the glute med, the quadriceps and hamstrings that we've discussed extensively, and then certainly the lower leg, that is the gastroc and soleus complex. Certainly other muscle groups play into it. We can talk about foot intrinsics, which we will, and as we discuss the other joints that are necessary for running criteria. But without getting into that discussion at the moment, let's just talk about the methods by which and the tools that are necessary in order to be able to adequately assess someone's readiness and to make meaningful and evidence-based decisions of someone's readiness and clearance for returning to running. So we have the isokinetic as the gold standard. In our good category, we have a fixated dynamometer with a time force curve. Ideally, the sampling rate, if we're going to get rate of torque development, needs to be 100 hertz per 100 hertz or 100 samples per second. Our force plates can do the job, but they are somewhat limited to certain muscle groups, most notably the plantar flexion. You could potentially make the argument that you could do it for knee flexion depending on the setup, but typically it's going to be more an isometric rig setup for your plantar flexors. Acceptable would be your fixated dynamometer without a time force curve. Again, it doesn't give you rate of torque development. It does give you the peak force. You could also use a pull gauge and or crane scale. For your sufficient category, you're looking at field tests such as a knee extension and or flexion machine that you would find at your commercial gym. Again, these are surrogate measures that are sufficient if you have nothing else. What is insufficient is manual muscle testing. Though it may have its role in screening and triage and determining neurological deficits, it can miss up to a 20% strength deficit from side to side, and certainly it would be very difficult to quantify someone's strength relative to body weight with it, and thus it really can't be endorsed as having a meaningful role in determining someone's readiness and criteria necessary for running. So let's put some operational definitions to what I mean by gold standard, good, acceptable, and so on. So the gold standard, anything that falls within this could also accompany the isokinetic dynamometer in that category. So it needs to be good reliability and validity. We'll use the ankle as the example here. So all ankle directions, all angles, and all speeds can be tested. All muscle performance constructs can be quantified. For your good category, the measurement tool needs to have good reliability and validity. All directions, all joint directions, except for the force plate, which is somewhat limited, as I alluded to in the previous slide. All joint angles can be tested isometrically. Time strength curves are available, thus you can get rate of force development, as well as looking at the normality of someone's force curve profile. So looking for force oscillations, looking at acceptability in regards to the reliability and the validity. All joint directions, again, isometric only here can be utilized with these different tools. No time force curve would be available, unfortunately. And then for the sufficient category, it's acceptable reliability. The validity relative to the gold standard would be in question, though it may correlate with what your isokinetic dynamometer force would look like. It likely will not give you the same quantifiable metric or value. I give you the example of testing someone isokinetically at 60 degrees per second knee extension. You'll likely get a different torque output than what you would get if you were measuring someone on a commercial knee extension machine, and that has to do with several factors and differences in the type of testing that is being done, and then also with the mechanical pulley system within the field-based test. And then the acceptable reliability but unacceptable validity. So isometric only, all joint directions is available, and it's easy to administer, but it really doesn't have utility, and I can't really endorse it
that is manual muscle testing for determining someone's readiness to run. So in summary, return to running criteria, the industry standards. This is a little bit more robust than what I presented in summary from the Rambaud article 2018. So pulling together multiple resources here. So the clinical criteria, pain should be less than 2 out of 10. It really shouldn't be present. No effusion or trace. Knee flexion and should be greater than 95%. Full knee extension. Muscle strength criteria, we've gone through this extensively thus far. So quad strength, the industry would recommend greater than 70%. I think that it needs to be higher than that. As I alluded to with the correlation graphs, that even at 90% LSI, that they're still in question as to whether someone's knee extension moment is going to, during running, is going to be acceptable greater than 80% from to the other side, or reestablished to that of prior level of function before the injury. Quad peak torque to body weight is going to be a better metric. Again, we know that when we looked at the actual running demands, that greater than 70% and up to 90%, depending on the running speed, is necessary for someone's force production. I know the units here are in metric. You can simply divide the metric values by 3 to get your English units. So your 21 or your 2.1 Newton meters per kilogram would equate to 70% of foot-pounds per pound of body weight, as we saw that even at 5.8 miles per hour, which was the slowest running speed that was investigated, that you still needed 73.5% of body weight. So that 2.1 is still kind of low, but certainly better than the 1.45 Newton meters per kilogram that has been touted. This is the criteria that we've really emphasized in this conversation, has been the 3.0 foot-pounds per second per pound of body weight, and greater than 80% LSI for their knee extension rate of torque development would correlate with a greater than 80% knee extension moment during their running gait and their sagittal plane knee flexion angle. Other criteria that has been utilized as well has been your single leg press, seated calf raise with tested isometrically, typically with a force plate 1.5 times body weight. That's from O'Neill in 2019, and then heel raise endurance, because we haven't gotten down to the criteria for the ankle, but you'll see that these also become relevant. These are criteria that have been recommended even post ACLR, because there's other muscle groups that also need to be sufficiently conditioned and have sufficient capacity in order to be able to run with a protective and healthy gait pattern. I think the functional performance-based criteria here is really important, and something that is also emphasized within our discussion has been the qualitative performance of single leg squat, single leg landing, and gait pattern in particular. Looking at that sagittal plane knee flexion angle, I think is super important, as I've alluded to, because that even just with a stiffened knee gait pattern with walking that is associated with increased osteoarthritis biomarkers, both in the joint itself but also within the blood serum, suggests that they would only further increase and be augmented with the act of running with higher impact loads. And then quantitative base, being able to land repetitively on one leg to evaluate single leg landing capacity would be recommended. How many repetitions here is somewhat in question. Harrington et al. In 2013 recommended 30 repetitions. But again, with running, it's going to be a lot more foot contacts than that. Patient-reported outcomes should be considered. IKDC has been described greater than 64 out of 100. Time post-surgery, that 12 weeks has been recommended as a median. That being said, likely not long enough. Rarely are people, at least in my clinic and under my exploration over the last better half of a decade with my clinical practice, are meeting that. That could be on me, I don't know, but when I'm speaking to other colleagues within the field, they also seem to recognize that people aren't meeting those the clinical criteria, the muscle performance, and the functional performance-based criteria within that 12-week mark. Training load criteria, so include a progressive running preparation period before starting to run is recommended. Skipping, low-level plyo variations can be a good loading stimulus to prepare an individual for the return to running. And so this conversation thus far has really emphasized what is the criteria, the physical demands and capacities that are necessary at the knee joint. That being said, running is a multi-joint, full-body endeavor. So what are the criteria that we can consider for the other joints around the lower extremity? And we're going to use a similar framework because it seems to be that the kinetics, the kinematics at the knee that are extrapolated at the different running speeds would give us better guidance than just would be expert opinion for establishing joint-specific criteria for ensuring that our patients are safe to run. And so the next portion of this conversation will focus on the hip and then the ankle respectively. So as I alluded to, we will focus on the hip. What are the kinematics and kinetics necessary for the hip during running? So the hip joint angles. So you have the very similar table setup that we had for the knee. You have the column headers of the different running speeds, and then you have the row headers of hip flexion, hip extension, and the joint excursion. So the hip's going to go through anywhere between 45 to 50 degrees during the running gait. And then we have flexion of necessary around 43 degrees at maximum. And then hip extension, people get, again, as you run faster, you can see that there's going to be more and more hip extension that is going to be necessary. When we look at the frontal plane, so the hip abduction and adduction, you want about at least 20 degrees. And then in the transverse plane, you want about 15 degrees of hip internal and external rotation. In what degree? Typically, people are looking at hip rotation in a flex position. Obviously, the maximum amount of hip flexion that is necessary here, at least if we're running at 3.7 meters per second or 8.3 miles per hour, that they're not going to get up to 90 degrees of flexion. So your internal and external rotation would be looked at in more of a neutral or slightly flexed hip, but not a 90 degrees flexed hip. When we look at the hip joint moments, so this is again looking at force or strength, and this is normalized to body weight. So it ranges for hip extension concentric and hip extension eccentric. The hip flexors really don't have a shock absorption capacity during running. They are certainly helpful and necessary with the swing phase, but during the swing phase, it's less likely that the joints will be disrupted, and thus we focus more on protecting the joints and with our criteria, and thus we focus on the muscle groups that are going to be most protective and most active during the stance phase and the shock attenuation. So we need approximately 47% of body weight force produced concentrically, and then eccentrically with the hip extension we would want about 37 up to 40% of body weight. Hip abduction joint moments. So we can see the different running speeds here. You can see that they're different running speeds than what was previously shown in the tables above and at the knee, and this is simply because it's a different study, because the study in question, Ordendorf 2018, did not look at the frontal plane hip moments, and so we can see here that the hip abduction eccentrically could be up to 7 times one's body weight, but the hip abduction eccentric, depending on the study that you look at, I think more appropriately, these would be better guidance metrics, would be 67 to 80% of body weight, depending on the speed at which someone's running. And again, these are tested eccentrically because typically body weight norms for concentric or isometric hip extension would be shy of that. It would usually be between 20 and 30% of body weight. So the hip power. So when we are running, depending on the running speed, we are going to produce rate of torque development at the hip anywhere between 1.2 and up to 2.3 foot-pounds per second per pound of body weight. You can see that the greatest amount of hip extension work occurs at 6% of the gait cycle, with 0% being at initial contact, corresponding to the early stance phase where the hip is moving into hip flexion. So you would test them anywhere. If you wanted to be joint specific, that the hip is going to be anywhere between 35 to 40 degrees of hip flexion. Keep in mind that even in an isometric setup is that the joint angle can change up to 15 degrees. So it would be ideal to actually have the hip slightly more flexed than what would be, for instance, if you wanted to get the force production at 40 degrees of hip flexion, even in an isometric rig setup, it would be ideal that you're flexing the hip to 55 to even 60 degrees, with the understanding that when the individual pushes out that there's going to be some shift in the relative joint angle. And so that would be the recommended setup. And you can see here that the position would be prone, the flex to 90, the hip at 30 degrees, that's 30 degrees off of the flex position of 90 degrees. Sets and reps is 3 to 5 seconds. And then norms for the force that you would expect relative to body weight was described by Powers et al. When they compared a healthy cohort to a patellofemoral pain syndrome cohort, is that the PFPS group produced about 0.46 foot-pounds per pound of body weight, whereas the healthy group was over about 2/3 of body weight that they were able to produce. The outcomes that you're looking for, again, are going to be rate of torque development. I would encourage you to utilize their RTD 2080. Why is this the case? To date, that I don't know of any research that has looked at this as being, but we as far as like whether, like what is our rate of torque development metric or time point that would most correlate with the forces that are produced during the running. But what we can do is extrapolate and utilize what information we do have available, which is at the knee, and the knee is recommended that the rate of torque development 2080 is going to be a more those values are going to be more consistent with those forces that we see with running, rather than taking the torque produced at 100 or 150 milliseconds. Okay, and then if we look at the hip joint power in the frontal plane. So unfortunately, we don't have good data here in regards to the rate of force development that is necessary or that has been described by Ordendorff in 2018 at the different running speeds. This being said, we can look at limb symmetry indices as a surrogate, and we can also look at the normative values that were tested from again, at Powers et al., where they looked at the foot-pounds per pound of body weight. And again, it would be it seems as though eccentric forces of the hip abductors correlate better with running mechanics and differentiating the individuals that have pain with running than does the concentric or the isometric alone. But those values could still be utilized and better than just guessing or using an omnipotent judgment of someone's strength for the hip abductors. And you can see the setup here, the individual lying in the side lying position, hip at 0 degrees of abduction and flexion, so a neutral hip position, and same sets and rep setup as previously. So I alluded to on the previous slide about the importance of the type of muscle contraction out of the hip abductors. And so this slide just delineates that a little bit further. So isometric hip abduction strength has been unable to differentiate runners with patellofemoral pain syndrome from healthy controls, shows strong correlation in gluteal muscle force during running. And so because it's been unable to do that, additional hip strengthening programs have shown to improve hip strength, single leg squat mechanics, but no change on running mechanics. And so what's the deal? Why we know that this muscle is highly important for single leg stance and for gait. With walking, we would assume, presumably from EMG studies, that it is also highly active during running, but why don't our strength assessments correlate to the gluteal muscle force during running, or differentiate our runners, or if we actually strengthen them and show meaningful mechanical changes with our other functional tasks, why it doesn't cross over to someone's gait analysis, gait mechanics. So isokinetic hip abduction strength testing, particularly eccentric, shows a stronger relationship with running mechanics. And so I would make the recommendation that that is how we should be considering looking at this. So we can certainly test them isometrically for the rate of torque development, but it would be recommended if we want to really be sure that someone's mechanics are going to correlate with the muscle testing, that it would be done eccentrically. So same setup as you saw in the previous slide. The joint arc here is going to be 30 to 40 degrees. Speeds are going to be 60 to 90 degrees per second. And the sets and reps are going to be between 5 and 10 with 3 reps. And the eccentric and concentric are shown respectively. So you can see the mean values. So they should be around, for 30 degrees per second up to 60 degrees per second, around the same, honestly. It's going to be, for males, 62% of body weight up to 43%. And then for females, it's going to be a little bit lower, anywhere between 44 and 54% of body weight. But there is the upper and the lower bound as shown respectively. So the eccentric to concentric ratio should be approximately 1.4, meaning the eccentric strength should be approximately 43% stronger. And so an interrupted stroke test will likely yield more reliable and valid results rather than combining concentric and eccentric into a single set. So just from a coordination standpoint and methodology and protocol for testing, it would be strongly recommended that that it's considered to just use one set where you're only testing eccentric, and then do another set where you're testing concentric, and rather than trying to combine them both. And so these values that we see here also correlate a bit more readily to what we see with running, with the approximately 60% of relative to body weight as far as the force in the frontal that's acting on the hip in the frontal plane. Yeah, I also just show that have been other positions that have been described. You can see the standing version there. I strongly, clinically, I found that the sideline position has been the better of the two options. But it's worth noting that there have been other positions that have been validated and shown to be reliable. Quick comment on hip abduction in the medial longitudinal arch at the foot. So key findings from the articles that you see cited there is that muscle strength at the hip, specifically individuals with normal medial longitudinal arch, generally exhibit greater hip muscle strength compared to those with pes planus orientation of their foot. Impact of hip exercises, incorporating hip exercises, particularly those targeting glute medius alongside foot exercises, can significantly increase the medial longitudinal arch parameters in individuals with flat feet. And I know we haven't yet gotten to the foot and the ankle in our discussion here, but we will when regards to the physical demands of running. And then the combined approach it also leads to a decrease in navicular drop and plantar pressures, enhancing arch height and stability more effectively than a foot exercise alone. Isometric hip abduction, during the short foot exercise, can increase the activity of the abductor hallucis longus while decreasing compensatory activity of the tibialis anterior. So you get a more coordinated muscle activation of the muscles that are ideal for supporting the arch, rather than the compensatory ones. And this suggests that isometric hip abduction can be beneficial in strengthening the medial longitudinal arch and improving the foot mechanics in individuals with pes planus. And so, as we'll see, is that rapid pronation, the rate of pronation, as well as the extent of pronation of the foot are going to be something that's going to be important for us to help our patients to be able to control. But this just further drives home the point of the importance of the kinetic chain. And though we're talking about our kinematics and our kinetics by joint, recognizing that there is correlation across proximal to distal. Okay, moving our conversation onto the ankle. Okay, ankle running demands. So let's talk about the kinematics. That is the joint excursion necessary. So we need, depending, and this can be highly variable. I will acknowledge that based off foot strike pattern, whether someone's a forefoot, forefoot, midfoot, or heel striker will highly determine the amount of joint excursion that you see at the ankle complex. But roughly speaking, you would want at least up to 20 degrees of dorsiflexion, such that you can be sure that they have adequate amount of joint excursion there. Keeping in mind, and we'll kind of show some time force curves here in a moment, the plantar flexion muscles are going to be dorsiflexion biased, meaning they're going to produce more force in a dorsiflex position. The joint excursion, again, is going to be highly dependent upon foot strike pattern, but roughly it's going to be about 36 degrees. The values assume a rear foot or mid-foot strike pattern, as I alluded to. Other sources would suggest that you would need 25 degrees and up to 10 degrees of plantar flexion, comparable to the excursion of 35 degrees. So that's other sources beyond the Ordendorff article that has been cited here. In the frontal plane, inversion and eversion, other sources, Ferber 2014 and Hawley in 2008, suggest that there's a joint excursion of about 20 to 24 degrees. So you need 10 to 12 degrees of inversion and eversion, and obviously the ability to control it is going to be important, but we'll discuss that in future slides. This is really just more around the joint range of motion. You can see in the image that's populated there with the graph, on the x-axis is going to be the percent of the stance phase of gait, and then on the y-axis is going to be the subtalar joint, specifically eversion and inversion respectively. And you can see during the initial contact to loading response that the foot's going to most rapidly go from an inversion state where you hit on the posterior lateral aspect of the heel, and then go rapidly roll through to the more of a flat foot and flat heel position, which will go into an inverted and determined by the patient's and person's capacity at the foot and the ankle to control that will determine like the amount of excursion that they will go through and how much into eversion will occur. You can see that this varies dramatically, anywhere between approximately with a range of 5 degrees of eversion up to 25 degrees, with a mean being around 12. And then when you're looking at external and internal rotation around the tibia, this is also important to consider. Once again, you're going to, as the individual goes into a more pronated or everted position, that's going to correspond to more of a tibial internal rotation. And that will get them into approximately 5 degrees. But again, there's quite a range there, anywhere between approximately 2 and up to 12 degrees. When you look at the ankle running demands and the kinematics, so looking at a similar graph to what we had shown on the previous slide. So let's talk about ankle pronation and eversion of the hind foot during running. So you have the duration of eversion, which is the longer duration of eversion is associated with injuries such as Achilles tendinopathy, the medial tibial stress syndrome, This suggests that the time that the foot spends in an everted position during the stance phase is a critical factor in injury risk prevention and reduction rather than the amount or speed of eversion. So the amount is like how much they actually evert, and then the rate, how quickly they go into that. The amount of eversion, while the amount of rear foot eversion is a recognized risk factor, especially in conditions like iliotibial band syndrome, it is not consistently linked to all types of running injuries. And then same with the rate of eversion, though it can put a lot of stress on individuals that have a posterior tibialis tendinopathy, and thus it may be relevant. It doesn't fall out as a predominant risk factor, at least based off these 5 sources and the scoping review of the literature that I've done thus far. So far and away, the powerhouse for forward propulsion during running is going to be the ankle plantar flexors, and our gold standard for testing methodology is going to be our isokinetic dynamometer. So there's multiple positions that have been described in regards to how to set someone up on an isokinetic dynamometer to test their plantar flexion strength. I've explored several of them. This is the one that I have found consistently gives the best results. By best results, I'm talking about the coefficient of variance and the reliability and the consistency of testing, as well as the patient stability and patient comfort. When the patient is more comfortable and feels more stable, then they're able to produce more force. I will also acknowledge that it is the position where I found that the influence of the more major muscle groups are also eliminated based off the straps that you can see there and the positioning of the limb. So the patient is in supine, knee extended, and hip at 0, pelvis, waist belt, as well as the tibial thigh belt. Stabilization is manually done by holding on to the frame. And then the normality of the force curve is what you're looking for first and foremost. I call it the strength curve profile. Peak and average torque, so limb symmetry index, and then torque to body weight. Total work produced, fatigue index is also considered, and then looking at ratio. So there's really 6 predominant metrics that would be considered when you're looking at the isokinetic dynamometry for your foot and your ankle, and in this case, particularly the plantar flexion. All right, so without losing the theme of our kinematics and kinetic demands for the foot and the ankle are going to be shown here. And so for your plantar flexion and your dorsiflexors, in regards to normalized force production, you would want to produce at least 2/3 of body weight out of the plantar flexion concentrically, and then that's going to be at 5.8 miles per hour, and then at the upper rung here, at least speed-wise, but you can see that there's a linear increase in the amount of force that is needed relative to body weight out of the plantar flexors as you get faster and faster, and here it would be a minimum of 80% of body weight produced concentrically. So I gave the 6 different criteria previously when we were looking at the positioning of the isokinetic. Here I give a little bit more specificity in regards to the criteria necessary. So we have the greater than 90% limb symmetry index. The mean normative data is shown there, and you'll notice that it's dependent upon the type of muscle contraction, the gender, as well as the speed of contraction. And so there's ranges that are given. Those ranges are 1 standard deviation around the mean. So the mean would be if you just took the difference between the 2 values. So if we just took that first value in the upper left-hand corner for males of plantar flexion concentrically, 49 to 65% body weight, then you would be looking at approximately 57% of body weight concentrically would be normative value there. And then we saw previously in the last slide that you would want the individual to be able to produce up to 80% of body weight, and those values can really only be achieved during the eccentric aspect of the of the testing range, and during those higher forces, which would be produced at 30 degrees per second. And when we saw on the last slide where the point at which the planar flexion strength or moment was the highest was during that loading response. So that would be during the eccentric, where the planar flexors would be working eccentrically and then pushing forward into the concentric direction for forward and horizontal propulsion. Speaking briefly about the curve analysis, so I alluded to earlier that the planar flexion muscles are dorsiflexion biased. What do I mean by that? So I'm in the figure below, I'm trying to convey that. So on the y-axis, you have torque in foot-pounds, and then across the x-axis, you have the ankle joint angles, with negative values of joint angle corresponding to dorsiflexion, whereas the positive correspond to that of planar flex position. And you can see that the normal strength curvature and profile of the planar flexors are going to be kind of like a childhood playground slide that you may see in your neighborhood, where you have a very strong spike in force initially due to the pre-resting tension of the planar flexors, which assist in the muscle to produce force. And then there's going to be a gradual decrease in the force production as the individual achieves more and more plantar flexion. The blue line here represents a healthy limb. The pink line represents an unhealthy limb, specifically an individual who was tested that had an Achilles tendon rupture. So you can see that their magnitude of force is less. You can also see that their strength curve is shifted to the left, such that it's more difficult for them to produce force in the more planar flex position. And this yellow bar represents the neutral angle. With the greatest force, as I alluded to, being in the max dorsiflex position, and then with the Achilles tendon rupture, typically because of the slight lengthening that can occur afterwards, that there can be a shift in the force curve, which makes it difficult for them to elevate their heel off the ground. Achilles tendinopathy, this would be an abnormal force curvature, and you can see that there's a dip that occurs right around the mid-range, and this can be associated due to cortical inhibition and or pain response, or a combination of the two, but it does not represent what we saw historically in the previous example of the strength curve of the individual that I was alluding to. At least even in the limb that was Achilles tendon repaired, had a relatively normal curvature despite the shift that we spoke about to the left. But in your Achilles tendinopathy, where you have kind of an M-shaped curvature, that would be less than ideal, and something that would be needing to be addressed, and identifying the root causes would be important in order to be able to normalize this, rather than just verbally coaching someone through the test. So similar to the figure that you saw on the previous slide, with the exception that things are slightly reversed and reflected. So here you can see that the force curve is below the zero, representing a negative torque because it's eccentric force production. And then though the numbers still represent the same conventional planar flexion with positive numbers and negative numbers representing dorsiflexion respectively, they are on different ends of the spectrum. And here, once again, you can see the inverted curve shape and strength curve profile that you saw concentrically. It would be, so it should be a reflection in inversion of what we saw concentrically. You can see that there's a little bit of lack of coordination here. It's not nearly as smooth and doesn't represent your same childhood slide nearly as well as it did concentrically. And this would be other examples of your abnormality in your eccentric strength curvature. So it can either be a single blip or multiple blips where people have difficulty with the coordinated ongoing force going through an eccentric rapid contraction. But given the fact that the plantar flexors are going to be important, depending on, again, the foot strike pattern, they're going to work eccentrically, but then they're also going to be necessary to be working concentrically for the forward propulsion. I'll quickly talk about the dorsiflexion strength. Usually they contract in a co-contractive fashion for joint stability, but are less important given not strange from the hamstrings at the knee that we discussed, that there's still going to be a predictable kind of pre-stretched greater force capacity in the plantar flex position, and then as you move to a neutral position, it's going to the force production is going to rapidly decline. So they, just like the plantar flexors are dorsiflexion biased, so are the dorsiflexors going to be plantar flexion biased in their force production. And so this is looking at a concentric and then an eccentric dorsiflexion strength respectively. Obviously noting that in the eccentric figure here, unlike what was shown in the previous graph, just out of convention in the way that the graph was set up, is that it's not an inverted, or the force here is not representing the negative, but it's still a normal strength curvature that mimics that of the concentric. So when we look at the ankle joint power and the rate of torque development of the plantar flexors, that they are working much more intensely in their concentric action than they are in their eccentric. Specifically, almost like twofold, just over a twofold increase concentrically than they are eccentrically, even though they do have that eccentric role. The testing protocol would be isometric, seated or supine, as shown historically. Ankle slightly dorsiflex into 15 degrees. You can see the cutoffs there of what we would want. Running ideal cutoff would be greater than 3.0 foot-pounds per second per pound of body weight, as shown above, and this would be in the concentric fashion. And then our rate of torque development, again, I would encourage us to be using the RTD 2080 for the rationale previously described at the knee, because research, at least to date, does not help us out as to determining what it would be at the ankle. When we're trying to determine the rationale for the ankle angle, when we look at the the moment within the gait cycle that there is the greatest concentric generation of force for the plantar flexion, the plantar flexors, what we can see is that correlates, at least time point wise, to about 15 degrees of dorsiflexion, which would be kind of mid-range dorsiflexion, and that would be the rationale also to be able to produce the greatest amount of force for the plantar flexors, as I mentioned, that they are dorsiflexion biased. Okay, so that was a lot of talk around the isokinetic dynamometer and how to go through the process of really doing your testing protocol and having your criteria that would establish the safety of returning to jogging for the foot and the ankle complex. That being said, I certainly recognize the fact that the isokinetic dynamometer, having access to such, is a luxury, and that I would say the vast majority of people and clinicians don't have that available to them. So what are the other ways that we can be testing out our plantar flexion strength?
Probably the most common performed assessment for looking at the muscle performance of the foot and the ankle is a single leg calf raise. just because it's common in clinical practice, I don't think that it's common practice to perform it in a structured or standardized fashion. I think that there's value in doing so because it enhances our reliability as well as the validity and the repeatability of the assessment. So if I could give some insights in detail as to how this may be executed, so you can see the patient position, single leg stance, locked out at 0 degrees at the knee as well as at the hip. The ankle can either be off the ground as shown, or it can be on a 10-degree slant board into dorsiflexion. The forearm length away from the wall is the distance that is standardized. So the individual adducts their arms, puts their fist out, and then puts their fist flush against the wall, and that would be their standardized distance from one time point to the next. The equipment that you're going to need is a tape measure for the heel height. A calf raise app is optional, which could give you the power, the heel height, the loss of heel height, as well as the number of repetitions. And then the metronome app for standardizing the tempo at which they perform it, and then a wall or stable object for them to support themselves on. You can see the starting position again at 0 degrees in this instance, but it can be in that dorsiflex position, which we spoke about previously, that the plantar flexors are dorsiflexion biased, thus it may be actually advantageous to do it through a negative range of motion. I provided the heel height statistics there for you in regards to the reliability, the standard error of measure, and what you can deem to be the minimal detectable change as a percent of the heel height. It's important to recognize that the performance of this assessment does not correlate nearly at all with someone's plantar flexion peak torque. And so it is really a different construct that is being assessed here. It is really muscular endurance and work capacity of the foot and the ankle and the calf muscles. And not to neglect its value. Again, I think it's important, especially with the amount of volume that people do with their foot and the ankle, be it running, jogging, athletic endeavors, non-athletic endeavors, just life in general, that it's important to have high work capacity, but just recognize what we're actually measuring when we actually take the number of repetitions or number of repetitions to fatigue. The tempo, as I mentioned, is going to be standardized at 60 beats per minute. That's a tick at the top and a tick at the bottom. I will have a consistent distance away from the wall, and then you can see that I use a ruler there to monitor their heel height. Usually the assessment drops when their heel height they can no longer achieve the same heel height of 80% of which they started. This would be considered to be a sufficient field test. Again, it's measuring muscular endurance rather than muscular strength. And I circle the knee only for the instance that a common compensation is that they're going to flex at the knee, and they also will lean into the wall rather than going vertically straight up, which is also a means by which they can gain mechanical advantage to improve the performance with the heel height elevation. Okay, so as I alluded to with the single leg raise test, you can utilize the calf raise app. It will monitor peak height, that is heel height, total heel height over the duration of the set, the percent of heel height loss over said number of repetitions, which will give you a fatigue index that you can monitor between limbs as well as across time. It will give you total work as well as total power that is produced during the set. The concurrent validity here is good to excellent for total work. Number of repetitions, 100% consistent with a linear encoder. It is important to note that using a heel as the surrogate center of mass for the body overestimates the total work by 21 to 25% compared to the gold standard of a 3D motion capture system, but it is able to precisely detect the relative difference between the limbs, and thus it's a reliable measure even if it underestimates the total power. And we also know that using the heel rise work test is valid when using it relative to the difference in the other limb. And it would also it's important to note that the total work is a more granular and more a valid metric to determine disability after Achilles rupture and or repair than is heel height or number of repetitions alone. All right, sticking with our quality assessment of the single leg calf raise test, I will say that there's been published research that would suggest that and shows that if quality assurance is not implemented with this assessment, that the number of repetitions and the overall outcome measures are significantly different. So you want to maintain the original footprint throughout the entirety of the assessment, especially if you're doing it on a slant board. Sometimes people will tend to drift backwards. For your foot and ankle mechanics, you want to have plantar flexion of both the ankle and plantar flexion of the foot itself. I'll give an example moving forward. And then the test stops when the metronome pace cannot be maintained. Heel height drops by 20%. Knee flexion occurs with proper cueing and they're unable to correct or unwilling. And then hip propulsion strategy was used where they kind of essentially use momentum base, lean forward, and or ensure, and you need to ensure that the majority of the force goes through the first and the second metatarsal head, rather than what you can see there is more of a sickling effect of the foot, as it's known, where you go into an inversion moment. Even though that is a natural means, when you get to your end range plantar flexion, you want to try and ensure that people that you're testing what you think you're testing, which typically it's going to be the gastroc and soleus complex with a bias to the gastroc given the straight knee. Yet you're not really looking for the compensation of the posterior or the tibialis posterior or peroneal muscles. And then the ankle maintains alignment with the second toe pointed due north or perpendicular to the wall. So again, as I mentioned, though the inversion of the rear foot is normal during single leg heel raise, excessive inversion would be an unbalance between the peroneal muscles and the tibialis posterior, and give me more of a compensation for weaker plantar flexors, and thus should be controlled. And again, without controlling these parameters and having a standard operating procedure, the outcome and thus the validity and the reliability of your assessment becomes more in question. So in the previous slide, I mentioned one of the criteria is having plantar flexion at the foot as well as at the ankle. And so I just want to give some examples of what that looks like, which would be in this upper left-hand corner. And if you see this, have them continue to train on. If you see this, it's an ankle problem. They're getting more plantar flexion at the midfoot rather than at the ankle joint. And you can see the small schematic there denoting the difference. And you can kind of compare and contrast that, particularly with the angle that is achieved by the lower shank as well as the calcaneus. The other issue is a foot problem, right, where someone plantar flexes at the ankle but then collapses through the mid-arch and they go into a more of a dorsiflexion at their midfoot. And then this is a problem on both accounts, where you have limited heel height and limited plantar flexion at the midfoot. And you can kind of see I've kind of plugged in the small lines there as an indication of red and green as those angles that are being adequate and those angles that are being inadequate as demonstrated in red. And so when you're looking at the plantar flexion calf raise assessment, yes, get your quantitative metrics of work, heel height, total number of repetitions, even the power if you're using the application I suggested. But then you're also performing these quality assessments that are giving you even more information beyond just the numbers themselves. All right, and then, yeah, you can't go wrong with the old-fashioned field-based testing, 1RM testing, and you can do it both with knee extended as well as knees flexed.
what I have found is that for the knee flex position, that the seated calf raise machine is the gold standard. It's really hard to otherwise replicate it. Otherwise, though, people certainly have found creative means by doing so. I find that I consistently kind of underload people, and they can do an excessive number of repetitions. I can't load them adequately enough, especially when we know that the soleus can, isometrically can produce 2 times body weight or more, depending on the caliber of your athlete and their strength. And then for the leg press assessment, you can see there that I have it's a little bit hard to see, but that red line indicates that I'm holding a stick to ensure that they are able to achieve the same heel height on each subsequent repetition and having them lock it out. I do it 60 beats per minute, similar to what I had mentioned previously with the standing version. And then I also will start people at 50% of their body weight, seeing how many repetitions they can do, especially for our goals are not pure strength, but we're still on the endurance endeavor. Obviously, you can increase the percentage of what they're lifting relative to their body weight if your goals are to actually measure strength, and depending on what your target 1 rep max is. Same stopping criteria as I mentioned with the single leg calf raise. Okay, so then what do you do with the results? So I found really good application and utility with this app, right? So you have the 1RM, I believe it's called, and I will just put in the number of repetitions that they achieved as well as the weight lifted, and it will quantify predict their 1 rep max, and then it also can be utilized for prescriptive means as far as if I'm going to send them home with X amount of repetitions, sets, etc., sticking by our strength and conditioning principles and trying to ensure that they're lifting a certain percentage of their 1RM. And certainly you can also utilize the calf raise app with both of those previous assessments that will give you the heel height, the power, and the work, both positive and negative, as well as the vertical height loss as shown there. So if you are going to be using the field-based test of the seated calf raise machine for your assessment, then the methodology that would be recommended would be you'd be sitting with the hips 90 degrees flexed, knees at 100 degrees, ankles about 10 degrees of dorsiflexed. The equipment would be your seated calf raise machine or Smith machine, a ruler or tape measure for heel height, and or the calf raise app as previously shown would be the recommended. The testing protocol would be a warm-up of 1 to 2 sets of 5 submaximal reps. Initial resistance, the load would be a comfortable lifting, a comfortable amount to be lifted, incrementally increasing by about 5 to 10 pounds. Subject performs 1 repetition for each weight increase. Rest periods of 3 to 5 minutes as per the best practice of strength and conditioning principles as described by the NSCA. And then the final attempt will 1 RM max, weight lifted for full range of motion. You get a failed attempt of 4 to 6 attempts. And then the pro tips for reliability and validity, full heel height achieved on the final repetition or recorded weight, and ensure neutral foot position equally pressing through the first and the second toe. The reliability has shown to be pretty good here. The MDC or SEM, that is minimal detectable change and standard error measure has yet to be determined. The coefficient of variance from one testing point to the next should be within 5 to 6%. So for some normative values of what you can expect for beginner to up to elite or advanced would be shown there for both the males and females. Once someone hits kind of that intermediate phase, they should be producing approximately 1 times body weight or 1.25 for males. A great assessment that has been popular by Evolve Performance, where you have the patient in a similar position to that of the single leg calf raise. The equipment that you're going to be needing is going to be a barbell or isometric rack. Obviously, a force plate is going to be necessary or a comparable system. I have a standardized warm-up comparable to what I utilize for individuals with ACL. So we go 3 minutes, stationary bike, 1 watt per kilogram. So if someone's 75 kilos, then they're going to be trying to put on 75 watts on the bicycle. This takes into equation, obviously, both the RPM, the revolutions per second, as well as the resistance on the bike. So obviously some of these resistance, the bikes, their resistance is arbitrary units. It's like 1, 2, 3, so on and so forth. But the watts are quantifiable and universal across different bikes, and so that's why I utilize that. You're going to want to have specific warm-ups of 3x3 second efforts, gradually increasing in their intensity. The tempo obviously is going to be isometric. They're going to be doing 3 to 5 max efforts per leg with 60 seconds rest in between the sets. They're going to be doing 3 to 5 repetitions of 5-second holds, 2 seconds build up, 3 seconds max effort. If you're looking for more for rapid force testing and your rate of force development, that you're going to be doing 5 by 1 second. It's going to be 10 seconds recovery, and you repeat it 2 to 3 times. The coefficient of variance with this is acceptable with less than 3 to 10% difference in the overall output from one repetition to the next and across time. The minimal detectable change in standard error of measure, however, is still yet to be determined. And as I alluded to, this is going to be a good test. It's going to have both muscle strength capacity as well as muscle power. Okay, so for the soleus biased setup, so there's been multiple setups that have been described. In the first column, you can see the force plate with the half kneeling position. Relatively a nice setup, particularly because it takes away the compensation that can occur with hip flexion going up into the dynamometer or whatever the force gauge is that you're utilizing, which can be an issue with the middle two, where you're using the more marketable setups of the force frame as well as the physiometer. Both have shown to be reliable and valid. Of note, with the half kneeling position, sometimes people can be somewhat unstable, though the image demonstrates, and what the authors have described is going arms across chest, having the individual hold lightly onto something stable can allow them to be more stable proximally and produce more accurate force output. If you're going to go with your do-it-yourself option with the handheld seated dynamometer, as shown there with the belt as well as the microfit handheld dynamometer, a couple of key things that you're going to want to keep in mind is that the belt really needs to be in a vertical plumb line over the metatarsal heads, and the belt tension is also going to be you're going to want to cinch that up. I'll give you further specifications as we go through this in order to ensure that the heel does not rise. So your testing recommendations is whichever one you choose, be consistent with the setup and the execution. Minimal effective padding to achieve the comfort of the test, especially if you're going to be looking at rate of force development and more rapid based onsets. That's going to be padding can influence the results. It can also produce instability depending on the amount of padding that is being applied. But you also want the individual to be comfortable. Applying more tension to the belt or the fixated system than you otherwise want, particularly with your DYI with the handheld dynamometer. So go 90% of the way efforts or tension with the warm-up repetitions. After the individual does that, go ahead and cinch it up the final 10% to ensure that the heel does not actually lift and that you don't get any energy leaks within the setup or the system itself. And then ensure proper seated height to avoid hip flexor cramping and to achieve best results. So that's going to be right around your 90-degree marker of hip flexion as shown. Okay, so what kind of forces can we produce and expect with this? So they're actually quite high depending on the demographic that you're looking at. So they consistently fluctuate anywhere between 1.8 and 2.6 times body weight. So with the Premier League football teams, Seth O'Neill has done an incredible amount of work with this as well as with the rugby teams, and has found right around 2.0 times body weight, whereas the Everton Academy has shown up to 2.6, and then in recreational runners, it's been shown to be 1.8 to 2.0 times body weight. Really good retest reliability. Standard error of measure you can see there in newtons, which equates to about 9 to 12%, which again is in the acceptable range. If your utilization of the do-it-yourself format or setup, body weight ratio percentage has been described. Not quite as high as that of the force plate setup with 127 to 136% body weight depending on your gender. and then you can see the minimal detectable change of what would be considered meaningful if you're going to track this over time. And with the fixed dynamometer, ideally, again, the microfit only gives you your force output, but if you wanted to, it would be recommended to have a hand dynamometer that gives you the force time curve as well, especially if you're going to be doing power. That's going to be a necessity. But otherwise, a good assessment for isometric force production and power. All right, so when we look at the demands of running for the foot, we'll look at the kinetics, the kinematics, and the muscle demands. So when we consider the role of the foot when we're running, or with honestly any forward locomotion, I want to utilize this diagram here to kind of express its function, such that the better we understand how it is intended to function, I think the better we'll understand the kinematics and the kinetics that we'll discuss. So on the first y-axis, that is the one to the left, we have the change in joint angle. And then on the second y-axis, we have the change in the muscle tendinous unit length as the foot progresses through the initial contact and through the toe-off phase. And then we see three lines. So the MTP extension is shown in the dark dotted line, and then the red dotted line is the longitudinal axis, and then the black solid line is the muscle tendinous unit and how it recoils. So we can see that as soon as the heel hits the ground, that the MTP joint as well as the longitudinal axis go through a joint excursion. Specifically, the longitudinal axis essentially extends and then recoils, as you can see it in that somewhat of an inverted U shape. The MTP joint does the kind of the opposite. It initially extends and then it flexes, and then it will extend again as it pushes off. And the muscle tendinous unit, I think, really alludes to the function and the role of the muscles of the foot as the joint angles change. So the muscle tendinous unit, as it goes into that big inverted U, is really where the muscles are being stretched, and then they're actively and elastically recoiling during the mid to later stages to allow for further push off and a more rigid lever that can translate force into the ground. And so the more of a inverted U that occurs, the more excursion and stretching also occurs. The ideal would be a more rigid foot, such that we're not getting an energy leak from the forces that are produced not only by the ground extrinsically, but also internally. And so the plantar flexor intrinsic foot muscles, we'll call them the FIM, actively lengthen during the early stance to absorb mechanical power and stiffen the arch. During that later phase, the FIM shorten to return the power and assist with forward propulsion. And it's this active adaptation of the foot stiffness that improves foot ground force transmission and reduces the strain on passive ligamentous structures of the foot. The plantar aponeurosis and the FIM act in parallel to regulate foot stiffness during the locomotion. And the activation of the plantar intrinsic foot muscles increase with gait velocity, significantly contributing to the energy absorption and thus the return. The contribution of the FIM becomes more significant as the gait velocity and force demands also increase. And here's another schematic of kind of that windlass mechanism and the stiffening as the foot translates through the initial to the late stance phase. So similar concepts are conveyed here. So the push off of the intrinsic foot muscles and the extrinsic foot muscles, that is the toe flexors, work as functional groups to stiffen the MTP and the longitudinal arch to augment the ability to generate propulsive power. Removing the capacity to activate the intrinsic foot muscles alters the leveraging function of the foot and ankle joint muscles that are used for the production of forward propulsion, and thereby they affecting the vertical jump performance and also require an increased proximal muscle activation during running. So toe flexor strength, both the intrinsic foot muscles as well as the extrinsic foot muscles, is immoderately correlated with the performance during a 50-meter sprint, pro agility tests, three-cone testing, and various vertical jumps. Both muscles, intrinsic and extrinsic to the foot, have greater effect on sprinting and horizontal jump performance than vertical jump performance, and the foot strength is a greater impact on horizontal oriented explosive movements, i.e. running, than is the vertically oriented ones, such as vertical ground reaction force with doing a vertical jump and or land. And so needless to say, the point of these first couple slides here are really to express what is the normal function of the foot during our forward propulsion and its importance in being a energy storing and returning structure rather than energy leak, and that our horizontal propulsion is dependent, our performance is dependent upon how well our foot strength is and how well it is able to restore that energy that is produced by the more proximal muscle groups. All right, similar to what we have discussed in previous portions of the presentation and along the other aspects of the kinetic chain is the range of motion. So the plantar flexion range of motion here of the hallux is what we're speaking of specifically, is anywhere between 3 and 43 degrees, and we need a ton of dorsiflexion depending on how much depending on the speed at which we're moving horizontally, up to 100 degrees of extension, but typically it's usually around 60 to 70 degrees. And you can see that the ranges vary there, with the hallux dorsiflexion during gait and running is between 60 and 84 degrees of extension. So less than 50% decrease in range of motion can be accommodated through the gait adjustments, such as the foot and the leg external rotation and decreased stride length, and increase ankle, knee, and hip motion. But it can only compensate so much, so hallux rigidus can significantly be a problem. And not only does it need a significant amount of motion, but the hallux supports up to 40 to 60% of the body weight, which is 2 times that of the lesser toes. And greater than 60%, 60 degrees of dorsiflexion is considered normal in barefoot walking on a level surface. It's also important to acknowledge the role of the sesamoids here. So sesamoid dectectomy, so when the sesamoids are removed, the tibial excision specifically results in 11% loss of flexor power, whereas when the fibula sesamoid is taken out, a 19% loss, and then when they're both are excised, a 32% loss. So that length tension relationship, not strange from that of the patella at the knee, really allows for a significant and meaningful force generation capacity of the hallux flexor. So the foot kinematics with running. So when we're looking at the power, so it's shown on the y-axis watts per kilogram, but this is consistent with what we've seen in our previous joints. And when we're looking at the joint power, we can convert this to percentage body weight per second. We can also convert this to the foot pounds per pound per second, and taking it out of the watts, so that we have consistent units across the different body regions or joint regions that we've discussed. And you can see that the the peak negative power is comparable, maybe initially, depending on the speed at which someone's going. So at lower speeds, there's almost a 1-to-1 positive power to negative power ratio, but as you get faster and faster, there's a greater amount of negative work that is produced as relative in relationship to the concentric power. And so it just speaks again to the importance of shock absorption and then to the restoring capacity of the foot as the individual gradually increases in their speed of gait. When we're looking at force production, so maybe for some this is an easier graph or figure to conceptualize. So on the y-axis we have work, which is joules per kilogram, and then we have the negative work when the foot is deforming, and then we have the positive work as the individual pushes off. And so the peak positive work is going to be close to 5.3 to 5.5% of body weight. And then the negative work is going to be significantly more. Again, we see that same relationship and ratio between the positive work and the negative work occurring over time with faster speeds. So as individuals gets to 9.8 miles per hour, then the work capacity of the foot intrinsics specifically will increase along the negative work at a disproportionate rate to an increase in the positive work, which is pretty much consistent regardless of the speed at which someone is traveling or running. And so I think that it's worth noting these kinematic variables because it gives us an idea as to the demand that is placed upon them and the importance of training them. I will say that unlike some of the other major muscle groups and joints of the lower extremity, the methodology here becomes a little bit more difficult to be able to isolate the true foot power production just because of the size and the multi-articular nature of the foot. Though hallux flexion can be measured and quantified in relationship to body weight. And then depending on what device that you're using to measure, the degree, the force per second can also be quantified in regards to capturing the power. I think I haven't seen a clinically friendly version of looking at the negative work or measuring the negative work. I think that would be a little bit difficult to do, but I will show you some clinical assessments that I utilize in order to determine or to ensure that the foot has sufficient capacity to be able to keep up with the rest of the kinetic chain in relationship to body weight. So this study is maybe a little bit tangential, but I think it's worth expressing because it was really profound for me in regards to how it further conveyed the importance of the foot intrinsic muscles. So you had 12 participants, males and females, around 30 years of age, plus or minus 6 years. The experimental condition was a tibial nerve block confirmed via a fine wire EMG from the flexor digitorum brevis during the electrical stimulation of the tibial nerve. And the control group did not have a nerve block. And so they did a walking and running. The FR stands for the Franz, the Froude number, which is essentially a standard unit that is that takes into relationship the gravity as well as the limb length of the individual. So it's more of a scientific standardization of speed for all intents and purposes. It doesn't matter significantly here, except that usually the transition from walking to running occurs at 0.5 Franz. So walking and running, and it's normalized to the individual based off their limb length. And so the task was walking and running on an AMTI instrumented treadmill, and for 60 seconds, and the data was collected for 16 seconds at the end of the trial, and they had the control and the experimental groups, the control being the healthy condition, and then the experimental condition was when they did the nerve block, and it was a crossover trial. So you have 4 graphs. So on the A and B you have the foot power for both the walking and then the running respectively. And then for the C and D, you have the walking and running, but ankle power shown. And then for both conditions, so the black dark line is the control condition where there's no tibial block. And then for the gray, you have that is the experimental where there is a tibial block, and thus the individual has a compromise in their foot intrinsic activation. You can see that there, with the ankle power, there's really no change, regardless of whether you're looking at walking or running, and we would expect as much because the ankle plantar flexors are not necessarily affected by the tibial nerve block as much as the foot intrinsics are. And then what we can see here is that the foot power is significantly increased in the control group, which represents the black line versus the gray line, which is the blocked group. So it shows that the foot power significantly drops in both conditions, which we would expect. But where is the compensation being made up for? All right, so in the cluster histogram here, you have the work on the y-axis for all three conditions: the walking, the slow run, and the fast run. And the black represents the control. The gray represents the anesthetized tibial nerve. And you can see that the asterisk represents the difference between the two cohorts. So in the walking group, as expected, the foot work drops in a significant fashion, but in the experimental group, the hip and the proximal muscles have to make up for that change. During the running, the ankle and the foot have a significant difference, and then once again with the faster running, the hip and the proximal muscles have to take up the slack for what is lost proximally. And so this just represents the importance of that. Yeah, you may get someone who comes in with maybe a tendinopathy around their hip, or additionally overuse injuries higher up the chain, but that may be indeed a victim rather than the true culprit, where the culprit may be indeed the foot, and the loss of energy at the foot leads to a greater demand higher up in the kinetic chain and potential overuse of those muscles.
All right, so let's start off with motor coordination. So I use a modified spring ankle test, which is a navicular drop test. It's formulated from and described by Cal Dietz in triphasic. So there's three components. So you have the single leg sit to stand, where the client goes from a non-weight bearing to a weight bearing position. You're looking for less than 5 millimeters of drop from the non-weight bearing to the weight bearing. Then you have a single leg squat, where you ask the client to go into a single leg squat position where the knee translates 2 inches past the second and third metatarsal. And once again, you're looking for less than 3 to 5 millimeters drop, with the ability to achieve that 2 inches over toe. So there needs to be sufficient dorsiflexion and sufficient tension within the arch, such that they don't go into more of a pronated position. And then the single leg calf raise, where the client performs a single leg calf raise with maximal heel height and is able to achieve a greater than 45-degree angle of the foot relative to the floor. And you can see the involved versus the uninvolved limb here. I don't think I need to clarify which one's which. And then in the third video, you can see that there's the utilization of a translucent goniometer, where the clinician can, in live time, monitor the navicular drop. Also, a classic index card can also be utilized in order to measure the discrepancies during the different phases. And this motor coordination test would be considered to be sufficient. It is more of a field-based qualitative assessment. That being said, I found good utility in not only determining someone's capabilities here, but also recognizing when additional work would be otherwise necessary. And you can certainly see discrepancies between one limb and the next. Okay, let's turn to muscle endurance. So for the foot intrinsic, I utilize, again, pulling from Triphasic and Cal Dietz recommendation. I really like these field tests. I found that good clinical utility, easy applicability, and then the assessment then becomes the intervention. So there's 4 conditions. So the first 2 conditions, you have knee straight. Condition 1 is in a plantar flex position. The second is in a max dorsiflex position. Condition 3 and 4 have knee flex positions. You're flexing the knee to 75 to 90 degrees, and then you're going into either max plantar flexion and or max dorsiflexion, depending on the condition. Your criteria here is that they should be able to hold each position against body weight for 60 seconds and without letting the heel height drop by more than 20%. The limb symmetry indices based off time should be within 10%, and that is in again, your outcome is in seconds. For higher level athletes, it is due to the additional demands that are needed for the foot, and in order to have that important energy storing capacity in return and counteract the deformation of the ground reaction forces as well as the intrinsic forces that are generated by the ankle, hip, and knee. It is recommended these athletes are able to perform the 60-second holds with body weight for greater than 20% of their body weight. Again, they can hold this weight, or they could also utilize a weight vest. Okay, and again, this is a field-based test. Recognize that its limitations, but the ease of applicability, its translation directly into interventions, the quantification of foot strength across time and the monitoring of that has really made it a really nice, good utility for testing people's foot intrinsic endurance. And here's just a closer caption, right? So you have the equipment, the different conditions, the modifications as shown in the left-hand portion of the screen, and then the different images. So you do have the option. I use a small, again, it's just a foam dowel with a Crayola marker stuck in between, or you can use a Sharpie as well, where the individual also has to flex around the dowel such that you engage the foot. The EMG of the foot is significantly higher with that, is what I found. Particularly people often feel it in the arch and in the foot specifically. And you can see the sagittal as well as the frontal plane positions. So we've spoken about the importance of the foot and the ankle, and specifically the role that the foot and the longitudinal arch plays during forward locomotion. We've spoken about the kinetics as well as the kinematics of the foot as an individual goes through different running speeds. We've spoken about how to go about testing that. This specific summary slide here really just kind of re-emphasizes the points that were made at the beginning of the presentation. Important contributors for the lower limb power transfer and push off are indeed the ankle plantar flexion power, the foot structures to resist the deformation, and the power of the foot and the ankle or plantar flexors is equally as important as the capacity of the foot structures to resist the deformation and efficiently promote power transfer during push off. And so whatever the hip, knee, and ankle power generation is, and whatever the capacities and capabilities are, if the foot system deforms under tension, is not able to transfer the power into the ground, your technique, mechanical efficiency, effectiveness, and ultimately acceleration and performance, forward propulsion, that is in our cases of discussion running, gradually degrade. Okay, any questions, comments, or feedback that you have, by all means, you can leave them in the comments section below. Here are the references for this presentation.